Well, good evening, everyone, and welcome to the Brian Crombie Radio Hour on Saga 960. You know, healthcare is an issue that people always talk about, and two-tier medicine is something that's been, a big political football in Canada. One of the things that I'm not sure if it's a lot, but certainly numerous people in Canada think about is medical tourism, going abroad. I've heard about people going to Turkey, about people going to Mexico, and about people going to Europe, the UK in particular, for medical tourism. And so I want to introduce you tonight to Giselle Mettam. She is the executive director at Meta Health Limited. It is a private healthcare concierge service in the UK. Giselle is joining us today from Kent in the UK, and she's going to tell us a little bit about her business, about medical tourism, about healthcare systems, and maybe we'll talk about some different healthcare issues. Giselle, welcome to the show. How are you?
I'm fine. Thank you so much, Brian, for having me as a guest on your show. I'm really excited to be here.
My privilege. Thank you. So medical tourism, is it a good idea or a bad idea?
I think that's a brilliant question, Brian. I personally think it's a good idea. And that's because I think that one of the things that happens when people are waiting for a particular healthcare treatment, operation, procedure, one of the things that can happen is that their condition can deteriorate. And if someone is in pain and they're on a waiting list and waiting a year, 18 months, 2 years, then it's, like we would do with any aspect of our life, we always think about a plan B. So from that point of view, medical tourism is an excellent option.
How'd you get into this business?
Interesting question. So it was very personal, and it's very much attached to my why. My dad, I live in the UK, and my parents live abroad. My dad needed an operation on his spine, and I didn't want just anyone to be operating on him. I'm a nurse by background, so I thought I needed to use my skills to support my dad to get the best care possible, and that's what I want for him. It's what I want for everyone. And so essentially, I did some research and found the best neurosurgeon in the UK. And I made all the arrangements for him. I said, Dad, you just need to come up to the UK, and I've got everything planned, all your appointments planned. You see the best neurosurgeon, and if that's what you need, then he'll assess you, and if an operation is what you need, he'll do it. He's the best man for the job. And so he came up and had his operation. Now, when he was explaining to me what would happen, the process that my dad would be in the intensive care unit, you say that to a nurse particularly, you say that to anyone, and it means something. It means that critical illness, that's what first thing, you say that to a nurse, and you start imagining that loved one in a comatose state with tubes coming out of them, etc. And so that really scared me, the thought that my dad was having an operation, although I knew he was the best surgeon for the job. And I remember waiting for the surgeon to emerge from theatre after he'd operated on my dad. I was with my brothers, and he came out and he said, the surgery went well, your dad's fine. That usually means my bit's fine. But he's going to be in a state in the ITU, but my bit's fine. And so I remember walking down the corridor towards the ITU, and my legs wouldn't take me down the corridor. I had to hang on to my brother, because I was thinking, I don't know what state my dad is going to be in. And I remember trying to push the door, and I didn't have the strength to do it, so my brothers had to do it, because I just didn't know what to expect. And I remember opening the door to the ITU, and there was my dad. He was the first patient. And there he was sat up, having a lovely salmon dinner, looking as if he'd had the best facial in the world. He was glowing, smiling. He said, come in. And he had just a little plaster on the side of his neck, and he just had major surgery. No tubes, no drains, nothing like that. and the relief, I started crying because of the relief. And then 20 minutes later, he said, look, I've got to have my physiotherapy now. It just had spinal surgery. And so he said, you guys will have to go and wait. And he recovered. He was discharged a couple of days later, and he was walking, up and down stairs, etc. And he was fine, and he recovered quite well from that particular operation.
Well, that's great. It's a fantastic result. Congratulations.
Yeah, I mean, that was some time ago. And I remember thinking, I want other people to have this experience. I want other daughters, other sons, other wives, other husbands to have this experience. So I want to do this for other people. And that was where the idea for Meta Health came from.
So, obviously you've got a great healthcare system in the UK. Was he coming from somewhere that does not have a good healthcare system or has long wait lines, or what was the problem that he needed to come to the UK for that health?
So he's from Trinidad. So my parents are from Trinidad, and I just wanted him to have the best healthcare possible.
Yeah.
And
but it obviously, it probably cost a lot more.
Oh, absolutely. It did cost a lot more,
but it was
yeah, absolutely. Minimally invasive, less pain, less trauma, and a faster recovery.
So, in Canada, we've got socialized medicine, one healthcare, one payer healthcare system. And as you mentioned on the top, wait times are an issue. Is this something that you bring Canadians into the UK?
Yeah, absolutely. I mean, we support any international clients to come to the UK for healthcare. So we've supported people from Africa, from the US, from the Caribbean. So it's anyone who would like to take advantage of, quite a very positive experience and addressing and some, if they want to address their healthcare needs and their healthcare condition so that they can go back to living life.
And how do they do that? You've got a website, I presume, that they contact you via?
Yes. So we've got a website. It's metahealth.uk, and our contact details are on the website. We're also on Instagram and Twitter. And so if people want to contact us, they can contact us on social media. They can contact us through WhatsApp. So I can let you have the number, but the easiest thing to say is Meta Health. That's METTA health.uk. That will take them to their website, to our website, and then they can contact us through that.
And do people pay the hospitals or the doctors or you or all the above?
Good question. I love that question, Brian. It's a brilliant question. So this is the point of concierge, is that we bring all of that together. So our whole focus, we start with the client, we do an initial healthcare needs assessment, and we start with what the client wants. And based on that initial healthcare needs assessment, we bring all of those together into a package cost. So once they've had their assessment and we've seen their scans, diagnostics, etc., we then research, and this is a critical part of the process, we research the best clinician that will give them absolutely the best outcome. And then we connect them via a virtual consultation. So we want them to build rapport with the clinician, and for the clinician to be able to ask them questions and do that assessment. So by the end of that virtual consultation, they will have a really good idea of what their treatment options are. And then we can kind of go to the next stage and think in terms of cost. And we put a package together that includes airport transfers, accommodation, all the transport within London, any aftercare that they need. And we look after them from the moment they arrive in the UK to the time they go home.
Fascinating. And is this a worldwide issue, or is it specific countries that come to the UK because they've got longer wait lines or inadequate healthcare, or where do you find that you're getting your clients from?
Okay, you're full of good questions, Brian. Another very good question. So COVID, the legacy of COVID is that worldwide, people are now waiting longer for elective care. And elective care means if you're scheduled for an operation, hip, knee, cataract, people are waiting longer because COVID displaced all of that. So worldwide, there is an issue with waiting times for elective care. And so the people who come to us don't want to wait anymore, but they want a high quality option, alternative to what they have presented to them. And so they tend to be searching, looking for that alternative. And we provide an excellent alternative here in the UK because the care is very high quality, it's well governed, and something that not many people know, that the healthcare in the UK is sometimes more than 50% cheaper than that in the USA. So whereas people from all over the world would be thinking in terms of the USA, when you think in terms of value for money, you could get the same or higher quality care in the UK, but for less than 50% sometimes.
Why, out of interest, why is it so much cheaper than the United States?
I think, okay, I think that's quite a complex question, but it's essentially the way that healthcare is structured. In the US, healthcare is very much a business. And it, the cost of healthcare varies from state to state. There's administrative costs, medication costs are really high in the US. The cost of prostheses really high in the US. And there isn't, I know that there's Medicaid, but the public healthcare system in the UK is very different. So we have the National Health Service, okay? And it's free at the point of contact for everyone who's eligible for healthcare in the UK. Now, what we also have running alongside is a private healthcare system. And that gives people in the UK and internationally the option of coming, being in the UK and getting private healthcare, which is a lot quicker. Okay. And what's really interesting is that the consultants who are in the NHS are the ones that have private practices. So private practice is by and large comprised of the same clinicians that are working in the NHS. So you're essentially getting the same care, just quicker.
So is the public system effectively therefore subsidizing the private system?
No, they run in tandem. They're parallel systems. The public system, is a public system in the NHS, and it faces the same issues that other healthcare systems across the world faces, i.e., the waiting times, etc. But we're really fortunate to have running alongside that the private healthcare system, and so you have private hospitals that are dedicated to private patients, and so that it isn't a subsidy. What you get is a read across. Because the consultants, the clinicians, the clinical experts that work in the NHS, they're the ones that have private practices that comprise the private healthcare system. So the high quality care that you get and the governance, because we're very, very, very hot on governance in the UK. So you then get this read across of standards into the private healthcare arena. But the waiting times are shorter because it's a private healthcare system. So if you can pay for it, you can get it a lot quicker.
Does that mean that therefore there's one healthcare system for the rich that can afford to pay for the shorter wait line, and another worse healthcare system for everyone else?
I wouldn't say that. I have worked in the NHS for more than 25 years, and I know that it's one of the best healthcare systems in the world. And I know that the staff in the NHS are they're passionate about delivering high quality care. And in actual fact, the way that the healthcare system works here is that although you have the private healthcare system in tandem, working in tandem, if there was an emergency situation, like if someone's having a heart or stroke, a heart attack or stroke, or some other emergency situation, they don't use the private healthcare system. They go to the NHS. Some may argue that it's a two-tiered system, and it's fine if people want to describe it like that. I see it as an alternative. So if people can afford to pay, or if they have insurance, some people just have healthcare insurance. They don't need to, but it's their choice to have it. Then those people who want an alternative have one.
Fascinating conversation that we're having tonight about international medical tourism. Our guest is Giselle Mettam. She runs a company in the UK that does international medical tourism, concierge service for people that want to come and go to the United Kingdom to get that elective surgery done. And she does everything from the second you touch down at Heathrow to picking people up by their accommodation, all of their interaction with the doctors, the hospitals, etc. Sounds fascinating. We're going to take a break for some messages and be back in just 2 minutes talking about two-tier healthcare systems, medical tourism. Does it make sense or not? Stay with us, everyone. Back in 2. Welcome back, everyone, to the Brian Crombie Radio Hour on Saga 960. Medical tourism, concierge medical services in the United Kingdom is the topic of conversation tonight. And I'm really interested in chatting with Giselle Mettam, who is the founder and CEO of Meta Health Limited, a medical concierge private UK healthcare company that does international healthcare tourism, et cetera. Because, understanding our healthcare system and where its weaknesses are, and what some of the potential solutions are internationally is something that I think we need to do. I think that we should tell everyone a little bit about Giselle. She's an award-winning, experienced senior operational director. She's got 22 years of experience in healthcare management, working from the front line as a nurse up to the board of director level. She's got extensive experience in health service improvement and transformation, strategic management, performance management, budget management, health and social care integration, and senior program management. She's passionate about coaching, personal development, and impactful, empathetic leadership. She's worked in the NHS, the National Health Service in the United Kingdom, and has provided a solid base of her work now in supporting national and international clients to access high-quality private healthcare in the United Kingdom. Giselle, we have this one-payer system in Canada where what you're doing wouldn't be allowed in Canada, and the reasons why would be that people, historically, there are obviously lots of people at different times that feel differently about this, and there's been arguments, don't think there should be 2 tiers of healthcare. Worry that if we have the 2 tiers, the private system and the public system, that there'll be one healthcare for the rich and a different healthcare system for the poor, or not even the poor, just everyone else. That the lineups or the wait times in the public system will by definition be longer if people are jumping the line in the private healthcare, because as you say, the clinicians work in both systems. And so therefore, if people are paying them to move up the line, then by definition, everyone else gets sort of moved back. And so therefore, by definition, the healthcare that the average person receives that's not part of the private system is going to be worse with longer wait times than it would be in the private system. And that is sort of a universal right that we thought people had for good healthcare. And so therefore, the private system would breach that universal right and give preferential rights to people that could afford. How do you respond to that?
I think I respect where people are, and I can understand. I have empathy for that position. So there are a couple of questions that I would ask, counter questions, and that would be, how many people are dying in Canada waiting for care? Because there will be a figure somewhere. And my other question would be, how many people are already traveling to other countries to expedite their healthcare? So
let's go to the first question. If there are, I don't know the answer to the question, but if there are people dying because they're waiting for healthcare, if we had a separate system the rich would move to the top of the line. The same number of people would still be dying, but it would be there for people that can't afford. So effectively, if the same number of people would be dying, if there are any dying, it would just be people that can't afford to pay to go to the top of the line. So it becomes the rich get better healthcare. Wouldn't that be the conclusion?
Not necessarily, because people can have health insurance that will pay for them to have alternative, an alternative, because that's what it is. It's an alternative. And what we don't want to do, especially where healthcare is concerned, is take away options. It would be okay. So if you had said that there's a one-tier system in Canada, and everyone gets seen and treated within 6 months, or 3 months or 6 months, and they get their healthcare expedited as a matter of course, because that's the policy, then that's completely fair. But if we're saying that there's a one-tier system, we didn't want another, we didn't want an alternative, or what you would call a two-tier system, because we don't want people to be able to jump the queue, then what you're really doing is taking away people's options and saying, well, actually, if you're in pain, you have to remain in pain and wait your turn. And I can't see who that benefits. It's certainly not benefiting the patient. It's appealing to people's sense of, equality, perhaps,
and fairness, yeah,
and fairness.
And I think the argument, has been that if you end up having one healthcare system, the private healthcare system for the rich, and another healthcare system for everyone else, that that you won't end up having as good a healthcare system for everyone else, because the rich will not demand it. The rich are happy with the healthcare system that they're getting, that they're paying for privately, and that's been the concept of universality of a lot of social programs, is that when it's universally available, then we make sure that it's good for everybody. Public school education would be another example, that as soon as you allow sort of that safety valve or alternative system that allows people to go to private schools or whatnot, then by definition, the public school system ends up not being as well funded, as supported, as good as the private system. And I come back to this, principle. I don't think people are dying on wait lists, but if people are dying on wait lists, by definition, the same number of people are going to die on wait lists. But if people are jumping the queue because they can afford it, it's going to be people lower in the income strata that are going to be the ones that are dying, which I do think is unfair. Unless what you're saying, which is also possible, which is when you've got a private system, there'll be more money contributed and you'll end up having more healthcare resources made available. And is that possible?
Oh, yeah, absolutely. What you're creating for people is an option. I personally have an issue with saying to someone, in the name of equality, you have to remain in pain and be debilitated. So someone who needs a hip replacement that's housebound because they're in excruciating pain, they can't do the things that they want to be able to do. Or it's someone who's got cataracts and can't drive at night, or can't see properly, or can't do their job because they can't see, can't go and see their grandchildren because they can't drive at night. So I have an issue with saying to that person, no, you've got to wait your turn and you will not have any options. I understand the point about equality, but lots of people who are not particularly rich have health insurance. In America, for instance. So if someone had health insurance, a middle-class person, or just someone who wants to prioritize their health, they don't have to be rich necessarily, they could use that health insurance to explore options. So it's not about how much money people have, it's about what their priorities are. And if they want to get treatment I have a real problem with people saying, no, you can't. You cannot get treatment because that person over there is in front of you. So you have to stay in pain and not have the option. The other thing is that irrespective of what we think, the facts are that more and more people in Canada and other places are traveling to places like Mexico and Turkey, as you said at the beginning, to expedite their healthcare. So it's already happening. People are already looking at options. What we provide is a really safe, well-governed, high-quality option. That's what we're doing.
Okay, so this is interesting that even though we have this principle in Canada of one tier of healthcare that's equal for all, and so therefore you cannot pay to jump to queue, even if you are in pain, you can't pay to jump to queue. You're right that there is a second tier. It's just not in Canada. It's an international second tier, and people will go to the United States, they'll go to Mexico, they'll go to Turkey, they'll go to the United Kingdom, India, lots of different places for different services, and sometimes they're going to go to the Mayo Clinic in the United States and pay a lot more, but because they want the best, what they perceive the best place to go, and then other times they'll go to Turkey or India because they can get this elective surgery done for half or a third the price. So if that second tier exists internationally, even though we may not like it, does that mean that we should have the second tier in Canada or the second tier in the UK?
Well, I think that's for the politicians to decide. But I think what would be of benefit is to address that question about how many people are actually dying on the way. I think it's a really important question to answer, and looking at the evidence, because I know that there's some evidence to suggest that, and then looking at the reasons. What are they waiting for? What is it that's driving this data? And also perhaps ask people, would you like to have, it's so important that we get opinions from the people who are actually, they're the ones experiencing it, and asking them, do a poll. How many people would prefer a private healthcare system in Canada? Perhaps they could use the UK as a template, because, there's some the cultures, etc., not dissimilar. So
what's the public reaction to the two-tier healthcare system in the United Kingdom? What do people think about it?
I think it's been such an integral part of the healthcare, the kind of healthcare system in the UK, that it's just accepted. And I think what's happening now is because, as I said, because of COVID, people are waiting longer on the NHS. So some of our clients are in the UK, and they make a decision that they don't want to wait any longer on the NHS. They understand that this is a COVID legacy, but that doesn't help them on a personal level. So they make the decision that they want to pay for their healthcare. They're not rich particularly, but if they had to buy a car or do renovations on their home, they would find the money. And if they're prioritizing their healthcare, and that healthcare condition is stopping them from doing what they want to do, then there are a section of people who will say, no, actually, I'm not going to have that new car, or I'm not going to do my home renovations. I'm going to get this done. And there are a number of people who have private healthcare insurance. So they, through their work, or if they made a decision that that's what they want to do, so they have their operation using their insurance.
Now, if they go and use private healthcare, do they still have to pay the same taxes to the public healthcare system?
Yeah, they do, because everyone's got to contribute to that. That's non-negotiable. But if someone decides that they want to do something different, then that's their choice. There are some situations where the private healthcare system in the UK may support the NHS. So, for instance, the government may say, okay, this waiting list for hip surgery is quite long, and we need to reduce that waiting list, or perhaps for heart surgery, because that tends to be the waiting list that produces not very good results in terms of people dying. If there's a waiting list for cancer treatment, or heart surgery, or something similar, then the government will say, well, look, we're going to purchase some capacity from the private healthcare system, and that's what they do. So there's that arrangement is in place. So what it does is that it gives people options in terms of resources. So if you think about it in this way, Brian, when nurses are leaving in their droves, they're leaving hospitals, government hospitals in their droves, because they're burnt out. Where are they going? A lot of them are going into the private healthcare system. So they're still in the healthcare system. And the government will say, okay, you can't tell people what to do, but actually we could use that capacity in a different way. So they pay the private hospitals to get those operations done. So everyone's then got options.
So if clinicians are going to the private healthcare system and nurses are going to the private healthcare system, having a second-tier private healthcare system, is that by definition a disaster for the public healthcare system because they'll lose good people?
I think that happens that will always happen. People will always move for all sorts of reasons. But there are people in the National Health Service who are dedicated, who want to, that's why they qualified, and they're sticking around because they have a passion. I have a passion for the National Health Service. I always will. Once you've worked in it, you become addicted to it because you became a clinician, a nurse, or a doctor because you want to help people. So what we find is that you do have a section of the workforce that will always be in the NHS. What I'm describing is the fact that the people who decide to leave and go to the private healthcare sector aren't lost to healthcare forever. They've just gone to another part of the healthcare system, which happens to be private. So you're now in a position where you've got the capacity over there, and you think, okay, what can we do with what we've got? Let's get this number of people operated on by the private healthcare system here. They've got the resources, so let's pay them to do it. It's a really simple and elegant solution to actually quite a complex problem. So I think it's great. I think it's great that we have that option.
We're chatting tonight about medical tourism and having two-tier healthcare. It's a fascinating conversation. Our guest is Giselle Mettam, who is running a concierge service in the UK. Giselle, remind us of the website people go to if they want to access your services.
It's metahealth.uk. So that's METTA health.uk.
We're going to take a break and come back in 2 minutes. We're going to talk about a couple of issues that Giselle's been talking about on her social media. Stay with us, everyone. Back in 2 minutes. Welcome back, everyone, to the Brian Crombie Radio Hour on Saga 960. Having an interesting conversation with Giselle Mettam today. She's the executive director at Meta Health Limited. It's a medical concierge company in the United Kingdom. She's coming into us tonight from Kent. It's a private UK health system where people with international medical tourism can go to effectively get medical services far quicker than they could in Canada. Some people would describe that as jumping the line, jumping the queue, but I think that Giselle believes that people should have the right to do that, that they can't be put in a situation where government is saying you've got to stay in pain longer than they otherwise might. And if there's an opportunity for them to get that service, she thinks that they should be able to. It is interesting that there's been such opposition in Canada to any kind of two-tier healthcare system, but seems like to Giselle that it's been working in the United Kingdom. Giselle, one of the reasons why people think that there is longer wait times and capacity issues or demand issues in the public healthcare system is because when you provide a service and you never charge for it, when it's free, that it gets over demanded, and that if there was some sort of disincentive for people to go to the emergency room with a cough or a cold, that if there was some sort of, you think about insurance, typical insurance, because this is what we've got in Canada is health insurance. If you think about insurance, there's a deductible, and that deductible is a charge that you have to pay that discourages you from, making use of your insurance on a fairly regular basis. What's the solution to too much use of our healthcare system, or is there a solution?
Wow, that is an enormous question, a really interesting one, and it's one that we've been battling with in the UK. Look, I think that there are all sorts of things, there are all sorts of factors at play when people turn up to the emergency room, and I have spent a large portion of my life dealing with this issue as a senior manager in the NHS, and had many sleepless nights because of it, because you can't stop people coming to the emergency room. That's what it's there for. I think it's about education of the population. I think it's about filtering, which is one of the things that we're trying to do here in the UK, a hotline that people can call, and they get an assessment by a nurse, and then there's an algorithm that takes them to an alternative to the emergency room. So there are all sorts of ventures and schemes being tried in the UK to see whether we could, redirect people elsewhere. And some of them work, some of them don't work. There's a psychology of the person who has a scrape or a cut and decides to go to the emergency room. What is it? And it's asking, what is it that would stop that person doing it? What would stop them doing it is if they could go and see a clinician somewhere else. And so that's one of the things that we do. So co-locating general practitioners with the emergency room, for instance. So, doing that quick assessment, what's the problem? You don't need to go to the emergency room. You can go over to the general practitioner there. And there are various means by which that could be managed. It could be managed.
Well, I think the only system we have in Canada is the queue, the wait line. And we have triage nurses that deal with you when you come in to emergency. And if it is an emergency, you get to the front of the line. And if it's not an emergency, you're waiting 6-8 hours for service. And so therefore, some people that don't really need to be there get pissed off, excuse my language, upset with the wait and just walk back out again. I also think we charge way too much for parking. And so that's a little bit of a disincentive to come and pay for parking. Again, another issue associated with this issue is that what we have in Canada, and I think in the United Kingdom, is insurance. And that insurance pays for the healthcare that you get. When you think about insurance, if you had a fire every year, or a car accident every year, or a speeding ticket every year, or you drank and drove every year, your insurance premiums would go up. I think a lot of people think that 50 to more percentage of healthcare issues today are because of lifestyle choices, whether you smoke, whether you're obese, whether you're, different things that you're doing. Should people that have bad healthcare practices, smoke, take drugs, drink, obese, don't, eat well, you can probably, for me, describe a lot of the issues better than I could ever dream of describing them. Should they pay more for the healthcare? Because in private healthcare, if they're going more often, they would pay more. So do you think that we should have a system where people pay more if they've got unhealthy lifestyle habits?
Another great question, Brian. Just a slight correction. Most people don't have health insurance in the UK. The healthcare, the National Health Service is free at the point of contact. So there's no, working people make a contribution to the National Health Service, but they don't have health insurance that will enable them to access the NHS. It's usually
it's the same in Canada. It's just that we call it insurance because we think of it. So the contribution to the government for healthcare dollars, we call it the Ontario healthcare insurance program. And so it is a program because the doctors, the hospitals, et cetera, aren't owned by the government, but they're paid for from the government. And so therefore, that's why it's insurance. And so all I'm saying is, should the contribution you make the tax dollars that you contribute for your healthcare, should it go up more if you've got bad habits?
Well, okay, so I think that's as I said, I think that's a great question. I think there's something, okay, so there's this concept of primary prevention and the role of the general practitioner. In the UK, the general practitioner has a list of people in their catchment area, and they're responsible for the healthcare, of those clients. So they would know if someone was, generally speaking, particularly if they use healthcare a lot, if they're a smoker, if they're diabetic, and kind of lifestyle, the lifestyle choices that they make. If there's some primary prevention or intervention with these people, i.e., they're enrolled in a program, or they've been screened, and they've had the conversation with nurses or healthcare professionals that says, look, these are the things that are adding to your risk factors. These are risk factors. If you smoke, if you eat lots of junk food, if you're not exercising regularly, and you have a poor diet, and you've got a sedentary lifestyle, these are risk factors that will mean that in a few years' time, you're going to have a heart attack or whatever it is. Or, if you're obese, this is what's going to happen. Now, if after having those interventions, there's no change in the lifestyle of that person, then I think that it's an interesting debate about whether that person should pay more for their healthcare interventions, because they've made the choice not to make those lifestyle changes. So I think that would be an interesting debate.
So it's interesting. The United States per person spends significantly more than the rest of the world on healthcare, and has lower mortality. Sorry, the age. Your age expectancy, life expectancy, is lower than it is in the rest of the OECD. Infant mortality, et cetera, is higher, et cetera. Canada in the OECD is 4th in spending, and the United Kingdom is 7th. So you actually spend less than Canada.
Interesting.
Per person.
Yeah, interesting. So there's something I think. So the healthcare in the UK is extremely well regulated. And the other thing to say is that because of public health messaging and, social media and, all sorts of things, I think that the UK, people in the UK are becoming more and more aware of the risk factors that contribute to chronic disease. And so I think their response to that generally is, I need to do more of this. I need to exercise. So whereas in America, in the US, they do spend a lot, per person. When you look at, generally speaking, when you look at lifestyles and you look at the rate of obesity, for instance, there's a high rate of obesity. There may be where you've got high infant mortality rates, there may be a high rate of drug use in those areas, and deprivation. So it requires more contextual data to understand the reasons behind that.
I think you're right, but I also think the system. The US spends 18.8% of GDP on healthcare. Canada 12.9%, the UK 11.9%. So you're 1 point lower than ours, but we both are 6 and 7 points better than the United States. And I think it's because of all the administrivia, insurance forms, litigation, et cetera, that they spend. It's an interesting conversation that we're having in regards to two-tier healthcare, medicine, international tourism, waiting in line, et cetera. I think it's fascinating. It's something that too often we have this ideological attitude in Canada against two-tier healthcare and against any kind of private medicine, which I happen to agree with. But I think we got to look at evidence and reality, and the fact that you're right, that there is medical tourism, that there is two-tier healthcare. It's just not in Canada. People go to the UK or other places for it. We're going to take a break and come back with some concluding comments in just 2 minutes. Stay with us, everybody.
Mm-hmm.
We're back chatting tonight with Giselle Mettam. She's the executive director of Meta Health, and it's metahealth.uk, is it not? That is your website?
Yes, that's correct, Brian. Thank you.
Which is a medical concierge company for medical tourism, private UK medical services. If you want to go to the UK to jump the line, as we've been describing it, but also get some really good healthcare. Before we go, though, Giselle, I've got to ask you a couple of questions about some other topics that you've been very prolific about writing on. Mental health. You talked about it costing an outrageous amount of money in one of your posts. What's the issue with mental health? Why is it such a big problem today?
I think the simple answer to that is that people are under a lot of pressure, and since COVID, since all the lockdowns, the incidence of mental health issues, mental health deterioration, has increased, and so when we talk about health, we try not to exclude mental health, because mental health and physical health are not mutually exclusive. So it's important to talk about both. And young people today are under so much pressure because of social media. And what we're seeing is a lot of young people developing mental health issues. These are issues that we have to deal with. We have to make sure that we've got systems in place to support these people so that they can be productive in their adulthood.
You quote some statistics, 15% experience mental health problems at work, 48% say their mental well-being has declined, 60% of people feel emotionally detached, 12 billion workdays are lost annually, 50 million years of work, cost the economy over $1 trillion. It's amazing. Another post that you've posted a few times now is on emotional intelligence. Why is emotional intelligence so important to you?
Oh, my word, Brian. In any situation, in any relationship, okay, so if you see two people arguing, it doesn't matter who they are, whether they're co-workers, whether husband and wife, whoever they are, when you see two people arguing, the reason that they're arguing is that one person is not getting their needs met, or maybe both. And the reason I talk about emotional intelligence is that if people can develop a level of emotional intelligence that will enable them to hear the other person and understand the needs of the other person, then the argument stops. You might have debate, but the argument stops. And I just think it's critical for any relationship that we have in life.
Giselle, thank you so much for joining us tonight and telling us a little bit about medical tourism, about medical concierge services that you provide, and an interesting discussion about your system of healthcare, your two-tier healthcare system in the United Kingdom versus our system in Canada. It's something that we're proud of our healthcare system in Canada, but it's something that we've got to make sure is the system that we want, particularly as people are going to the United Kingdom, Turkey, Mexico, India, etc., for US. For services that they're obviously not satisfied in receiving on as a timely basis, and maybe in the same quality as they want in Canada. It's interesting. Thank you very much.
Thank you so much for having me, Brian. It's been an absolute pleasure to be on your show tonight.
That's our show for tonight, everybody. Thank you for joining us. I remind you, I'm on every Monday through Friday at 6 o'clock on 960 AM. You can stream me online, even from Kent, UK, at www.saga960am.ca. All my podcasts and videocasts are available on my website, briancrombie.com. Good night, and Giselle, a pleasure. Hopefully, I won't have to come and make use of your services, at least too soon. Good night, everybody.
I hope not.